Benvenuti, cari amici.
Welcome, dear friends, to this conference. The title is Time to Start Again and Get Back to One's Cure. Health Can't Wait. I am Riccardo Zagaria. I am the CEO of a drug company. And what is the idea behind this conference? It is the observation of the reality that we have been experiencing. And maybe I had a privileged point of view in a way, because in my company, every week during the lockdown, we received the weekly details of the sales of drugs. And I realized with my collaborators that people in Italy stopped taking care of themselves. And how did we understand this? We understood this because the sales of chronic drugs, for example, those used to treat the heart system, decreased. It's not just about antibiotics, but those important drugs were sold less. And so, seeing all this, we have asked ourselves, how is it possible that such important drugs decreased in sales by 20%? It means that people now are scared of treating themselves. And so the conference we organized today is going to focus on this, on the reality that we have experienced, and to try and discuss this with the friends that will join us and understand how we can plan the future so that what has happened may not happen again. Today, in this virtual round table, there will be 4 friends, and these are Dr. Lucio Corsaro, who will comment on these data that I've mentioned. He's a general director of MEDI-PRAGMA that is specifically focused on this. So he's going to talk about the facts today, and on the basis of the facts that he will be presenting, we will ask for a comment first to Dr. Filippo Anelli, who's president of the Professional Association of Physicians, Surgeons and Dentists of Italy. So he represents the physicians in Italy today, and we will ask him to interpret these facts. And then we will ask Professor Lorenzo Mantovani for a comment. He's director of CESP, and so he will talk about the possible consequences and economic consequences of the fact that people stopped taking care of themselves because of COVID-19. And finally, I will ask for some recommendations to our experts, both Professor Mantovani and Professor Corsaro, to share with Professor Maggino, who works side by side the Prime Minister Giuseppe Conte in the unit that is in charge of this. So we will ask her a final comment about this phenomenon. Without further ado, I will start the conference. Each presenter will have 10 minutes, and we will now begin with some slides by Professor Corsaro. Is Professor Corsaro connected? Yes. Hello, good morning, everybody. Well, thank you for the invitation. As MEDI-PRAGMA, we do market surveys in the health sector. And we have been dealing with the COVID issue since November abroad. And in January and February, we started to deal with this issue also in Italy. Afterwards, we have launched a research plan to verify what is going on and to outline possible future scenarios in a post-COVID situation. I will now show the slides of my presentation. So in this activity, we have started this research project considering a number of interviews conducted with the population on a monthly basis. So we have interviewed the physician population on a monthly basis, and also we have interviewed decision makers. I will present some data about the interviews on the physician medical population and then subsequently on the citizens. What can we see in this slide? Basically, we make a comparison between February 2020 and July 2020 in terms of access to outpatient clinics by patients. In July, you see that patients' access has not got back to the levels of February. In particular, there are some categories, for example, dermatologists, general practitioners, and there are some categories that treat patients in their unit. And what are the reasons for this? One of the main reasons is that because of the COVID, there were security systems that had to be implemented. And so even if the outpatient clinic was open, the number of consultations, the number of examinations was reduced. And the same goes for the number of accesses by the population. The consequence of this reduction in access can be understood by looking at this slide. This is datum that was published in June that concerns the reduction of admissions in Italian unit concerning myocardial infarction, and the reduction of admissions had as a consequence an increase in mortality. So it is fundamental now to monitor and guarantee access to healthcare for everybody to reduce mortality and also other consequences and other complications. In this slide, you can see the trend of the average consultations for general medicine that we have calculated throughout the year on a weekly basis. The first bar on the left concerns May 2019, and the last one, the third week of July. As you can see, there was a reduction during the lockdown in the number of examinations. In red, we have physical examinations, or face-to-face examinations, whereas the green bars concern distant examinations, telemedicine. I would not call them teleconsultation, but these are contact on a remote mode made by doctors with patients. During the COVID, there was a big increase in this type of contact, but at the end of the lockdown, that is at the end of June, there was another increase in the number of face-to-face visits. However, it is not the same level as it was in the past. As I said before, there are different reasons behind this. There's organizational reasons in the organization of the healthcare system, but also the population was a bit skeptical and did not really want to go to hospitals and to ambulatory services. In June, we asked citizens whether in June they had a medical examination that was not related to COVID-19. And 37% said yes, and 68% said no. In 68%, in this 68%, 48% said that if they had the need to have a medical examination for urgent matters, but because of COVID, they preferred not to do it, not to have it, or they just postponed it. There are two main reasons behind this. First, fear for infection, and second, the wrong perception, wrong from my point of view, that hospitals and outpatient clinics can be places at greater risk of infection. these are the main reasons. And then there's a third reason that is a bit of an alarm bell, that is the reason due to economic resources. In our interviews, in our surveys, we found that some people do not get access to healthcare because of economic problems. It used to be 5-6%, but now it's 12%. So there are big questions here arising for the future. Those respondents that said that do not go to hospitals for an examination, but they will need an examination. We asked how they get in touch with the physician. In 74% of cases, they get in touch by phone, 60% by WhatsApp. And the reason is for this contact is the renewal of treatment plans, or the need to deal with the red tape. And then the other reason is to replan access to admissions, access to examinations after the summer, so in September or October. In terms of attitude and behavior of citizens, we have tried to understand what is the position of citizens towards vaccination for flu or for COVID-19. So we asked them whether people would have the intention to take the flu vaccine, and 50% of respondents said yes. There is a peak for people over 65 years old that declare to take the vaccine in the 69.6% of cases for flu. And then we compare this with the responses obtained in terms of a possible vaccine for COVID, and we see that there is more intention, 62.1% in the general population to get the vaccine, and there again there is a peak in the elder population, 61.6%, and then there's employees and workers for 66.2%. And from this slide we can understand a couple of points. First is that there is greater intention at this time, we refer to June, towards vaccine for COVID compared to the flu vaccine. And second is that for both types of vaccine, the percentages are pretty low compared to what we would need to have herd immunity. That would be minimum 75% of population. And the last slide I would like to share is this. Basically, we have a summary of the situation with some comments. Basically, there has been and there is still a reduction in ambulatory examinations. There is an increase in the demand for digital prescriptions on a distant mode. Many activities have been suspended. We've talked about examinations here, but also surgery or operations have been stopped in many cases, and other planned activities. And then, on the other hand, in terms of future scenarios, this is what we may expect. There might be an increase in the collaboration activity between the hospital and the population. The lesson that we have learned from COVID is that the community is fundamental to preserve healthcare services for the population. If community services do not interact with the hospital, it is a problem. When I say community, I mean general practitioners and local services. If there isn't any interface, there isn't a coordination with the hospitals, it is hard to manage admissions and to manage the health of people. On the other hand, the digital component is fundamental for the future of sustainability of our system. Thank you very much for attention, and I give the floor back to the moderator. Thank you, Dr. Corsaro. Thank you so much. And now I will immediately give the floor for a comment to Dr. Filippo Anelli, who is a president of the Association of Doctors in Italy to ask him how he has experienced this situation and what is his comment and what is the view for the future to get out of this problem. Professor Anelli? We cannot hear Professor Anelli. Perhaps now the connection works? Yes, there he is. We have been given an overview of the situation that might be described as dramatic, certainly due to the fact that COVID-19 really found us unprepared. The hospitals have been reorganized. Some of them have even become means of spread of the disease. But the fact that most parts of the patients have renounced to treatments, this should not be underestimated. And this is due to the transformation of the organization in hospitals in view of the COVID emergency situation. And so there has been a reduction of availability towards citizens in terms of beds. We've mentioned surgery services and also availability of ambulatory services because of safety reasons. Some data really impressed me. For example, the reduction by 33% of heart examinations for important diseases, and we have seen how this has increased the mortality. And then the 53% that was mentioned of pediatric examinations for children. Then, so all this obviously have worsened an inequality situation that we have always denounced in our country in terms of recovery of those survival percentages that really divided the regions from the north from the regions of the south in Italy, but also the whole country. There was a gap between the rich and the poor, and those with more education and less education, those living in city centers and those living in the outskirts of cities. And this datum is also supported by the fact that renouncing treatment moved from 5 to 12%. Because of lack of economic resources. Unfortunately, we will see the effects of this in the future by seeing the survival indicators. The survival indicators are one of the important indicators of efficiency of our system. Then the telemedicine, there are organizational aspects here with negative consequences. For example, there was a reduction in the number of examinations, but still this allowed for an optimal level of communication with one's physician. And there are many positive effects. All of a sudden, there was the dematerialization of prescriptions. We had been working for years on this, trying to transform paper-based prescriptions into electronic prescriptions. But now with COVID, there's no paper anymore. Now we have the electronic medical report. We use WhatsApp, we use emails. So all prescriptions now have been dematerialized. And also the treatment plans have changed. The GPs have been authorized to renew automatically treatment plans, showing that the whole system was more based on a bureaucratic factor. But during the COVID situation, physicians had to take on the responsibility for administering certain drugs that up until now were based on a double prescription system. There was first a prescription by the specialist and then the prescription by general practitioners. Then the other thing that telemedicine might develop in the future, rather than tele-examination, it is the teleconsultation with the specialist. That is, the specialist, in fact, might become a sort of consultant for the general practitioner in a very easy way, that is at home, at the patient's home, supporting the work of the general practitioner wherever necessary. So telemedicine becomes a fundamental tool to develop home-based treatment and to develop monitoring of chronic patients that are at home, and that would benefit from the advantages of this technology. The other important point is about safety. The fear for COVID. We saw that 47% fear COVID and 35% fear that hospital facilities might be a dangerous place because of the spread of the virus. I believe that safety should become one of the main points of focus for those in charge of managing public healthcare services and of physicians as well. Unfortunately, we have registered 176 deaths among physicians because of COVID-19, and this could have been avoided if they had used the safety devices in place. So treatment must be safe both for physicians and for citizens, and citizens must feel safe when they go to health units and facilities, knowing that they are not risking, they're not running any risk, because there are certified procedures that make these places safe enough to have examinations there. So safety is a right for citizens, safety as a right for professionals and not just as a concession. The last point is just an invitation to everybody to think about what has happened. We have had a system that have focused on the economic control of expenses, reducing the number of staff. Today, I believe that we got at a time when we've had intervention on the part of the government, Minister Speranza, and this trend has been changed. There's a lot of resources that have been invested in the healthcare sector over the last 12 months. 6-10 months, and this shows that there is a special attention by the government in trying to revert this trend that we believe has determined a number of problems, because there was a lack of physicians, of specialists, and there was a lack of a good plan in this respect, and new resources were needed, and this would have allowed for more equality in terms of access to cures. And I think we will continue this debate about the fundamental role of the Ministry of Health as a point of reference to overcome inequalities in our country.
Thank you very much, Ms. Anelli, for the very interesting food for thought that you highlighted. You're basically telling us that COVID-19 was definitely nothing that we would have wished for. Certainly, however, we have to learn the lessons and make the most out of the lessons learned in terms of elimination of red tape. Now, I would like to leave the floor to another guest. He's Professor Mantovani, joining us directly from his car. I would like to ask him for some comments, and I would like him to comment on the social and economic issues of patients not treating themselves. Professor Mantovani, you have the floor. Thank you, Riccardo. Thank you very much. Unfortunately, I'll call you Riccardo and not Mr. Zagaria. I think my car would stop if I tried to do what I am doing, so connecting with you while driving. And this is a major issue in terms of safety. So let's go back to your question. From the point of view of health, we have increasingly progressed over the last 50 to 60 years. We significantly reduced heart, cardiovascular diseases. If we went back of 40 years, we would have twice as many deaths for infarction and twice as much as deaths for stroke. Treatment has progressed thanks to our specialists and thanks to the conception of new equipment and the development of new drugs. If we are no longer able to provide our patients with all of this, we run the risk of going back. And this has a twofold effect. A first effect lies in the increase in mortality increased number of deaths out of the total population, as well as of incidence. In other words, the likelihood of those running the risk of suffering from this disease because of delays in treating them. And also because of the fact that there are issues in terms of safety in accessing hospitals. Of course, there have been problems like these during the months of the lockdown, and we will probably register the consequences of this over the next 12 to 15 months. The consequences might be even worse than we think today. How can we help people start again and go back to their treatments? There are events which have significant social and economic events. Let me give you an example. For about 20 years, I've been dealing with chronic degenerative diseases, especially cardiometabolic ones, and actually over the last 10 years, I've dealt with atrial fibrillation, which is a pathology that concerns about slightly more than 1 million people in Italy. Since the beginning of this year, we have not registered from 70 to 100,000 patients have not been part of our records. These are people who have not accessed care for a number of reasons. The fact is that we need to kind of identify these people. A person who suffers from atrial fibrillation on average also has 2 or 3 additional risk factors. About 60% of resources are normally used to manage about 20-25% of patients who are the so-called multi-chronic patients, so patients suffering from multiple diseases. And atrial fibrillation, like diabetes or heart failure, are very interesting models to study because they never happen alone. They normally have comorbidities. There are a couple of reasons, risk factors. So first of all, overweight, then smoking and aging. The patients whom we have not registered yet have a risk that it can be from 10 to 15% every year to be subject of a stroke, and stroke patients have a cost. Also, both health and social costs. So a person who suffers from stroke in the first 2 years after the seizure is very expensive. It costs from 15 to 20,000 euros. So if we are able to identify and treat these patients in time with therapies, this risk, which is about 12% every year, goes to 2 and 3% every year. In other words, if we do not treat these patients, the following year, so over the next 12 to 24 months, we will spend between 200 and 240,000 euros every 100 patients that are left without a diagnosis. But if we identify them and if we treat them, the average cost of a therapy, of the total therapies, for example, all the therapies needed by these patients costs about 600 euros every month. So if we identify them and we treat them, we expect to spend about 60,000 euros. If we do not find them, if we do not identify and treat them, we expect to spend over 200,000 euros. And from a financial point of view, of course, this is not of benefit. Furthermore, there are significant social effects of not treating patients. Anyone who has a patient who suffered from stroke, all his or her family members know that there are severe social costs in terms of changes of the life and of the entire family members of that person. This is just but an example, and I'm talking about 100,000 people on average that we have not yet detected. If we multiply these figures by 1,000, we are talking about tens and hundreds of millions of euros. And the same can be said for patients suffering from diabetes or heart failure, for example, or the whole set of cardiac and metabolic diseases. Of course, problems are easy to identify, solutions are much harder to detect. Some years ago, I remember that Mr. Anelli identified one solution, in other words, the elimination of red tape and a better integration of care, which means creating networked organizational methods. These methods have a great advantage because if you've ever involved in a network, you know well what I'm talking about. In other words, if there's a problem in one knot of the network, we all know that the entire network suffers from this. So if you think, for example, of the areas, of the red areas, of the outbreaks of the pandemic, there are certain knots of the network which have to be closed. But if the other points, the other knots of the network provide support, of course, the situation can be improved. So probably we should also add a third level. This model so far has been conceived to address specialist care, but we should extend it and make one step further and focus on hub specialist care, then spoke specialist care and territorial level, a territorial level of care. Another aspect that is connected to this lies in the fact that this is inevitable because resources are limited. And I'm not only talking about financial resources, I'm also talking about human resources. So, for example, in the aftermath of the Second World War, we had the phenomenon of baby boomers. And we now have people, those baby boomers, in which the problems I have just described can reach their peak. So we're now dealing with millions, in other words, from between 20 to 30% of the Italian population, which means between 12 to 15 million people. So people who are in this condition, so we first had the baby bust, then a limited number of people entering the schools of medicine, and then a limitation, a reduction of the number of young doctors addressing specialty schools. So for a number of reasons, limitations, then aging, and at the same time an increased number of patients to treat. So the network model is the model that can better integrate each person's skills. The alternative to this is lots of deaf people, lots of disabled, and bankruptcy. Lorenzo, thank you very much for your contribution. Like Mr. Mantovani did, I would like now to ask Mr. Anelli to provide us with a series of recommendations together with the ones given to us by Mr. Mantovani, recommendations to provide to Ms. Mangino. So, Mr. Anelli, how can we go out of this situation? How can we make sure that starting from next autumn, people can go back to their doctors and start treating themselves again? What kind of recommendations can we give Italians and also Ms. Mangino? Ms. Mangino, who a professor of social statistics, and an expert at the Prime Minister office. So a first office can be the one of outpatient clinics and hospitals. In other words, an idea could be to organize diversified pathways for COVID patients and non-COVID patients, so that we do not reduce the number of consultations, both in outpatient clinics and in hospitals. Then there's a second issue, territorial medicine. Local territorial medicine should be enhanced and strengthened. That is fundamental. We have a general medicine sector which is based on a model dating back to the 1960s and 70s. There are tools, the sphygmomanometers, the endoscope, so kind of outdated tools. And we also need more collaboration. There should be the collaboration between several specialists. We shouldn't be left alone, so that if multiple players are involved, then together they can use all the diagnostic tools at their disposal to take care of the health of their patients. Another issue is, like I said, the reduction or hopefully the elimination of red tape. Enhanced access to the professional practice should be favored. More autonomy, which also means more responsibility, more accountability of the professional, which means being free in doing prescriptions, more compliance with principles related to the correct use of drugs, to the correct administration of drugs. An increased level of red tape does not provide for equality among citizens. Furthermore, there's the issue of inequalities I was mentioning before. I believe that the Ministry for Health should be the kind of authority in charge of protecting the health of its citizens. This means that they should adopt and implement rules capable of giving the Ministry for Health more authority, so that more equality is guaranteed in accessing care, which is also enshrined by our Constitution. Thank you very much, Mr. Anelli. Before leaving the floor to Ms. Maggino, I would like to briefly comment on this. The first question I have is, how can all the stakeholders involved in the health sector, like drug companies or general practitioners, how can we network, as suggested by Mr. Mantovani, so as to avoid listing data of those who have not accessed care, and in order to make sure that in the future the lessons learned during these months can be truly benefit everybody. And so that everybody in Italy can make sure that the health system in Italy becomes more effective, and that we avoid the scenarios that Professor Mantovani was outlining at the end of his contribution. So phenomena which also have a huge impact in terms of human life and social effects as well. So I would now like to leave the floor to Ms. Maggino. We started from a current overview of from an overview of current data. So what are your next steps? What do you plan to do to make the most out of the recommendations made that emerged from this meeting? First of all, good morning, and thanks for inviting me. Also, thanks for the useful suggestions that have been put forward by previous speakers, and that started from the data that were presented. So the figures shown are very interesting, and they depict a very clear scenario. So What does it mean to look to the future? First of all, we need to understand, if we want to do this, we need to understand what happened, what has happened in the past. There cannot be any future if we do not understand what our past was. The health emergency and the pandemic have highlighted the weaknesses of our country. However, these weaknesses were already present before. They were not brought about by the pandemic. And this is something that should be made clear to everybody, especially if we are looking for solutions. The system has shown that it is not sustainable. The true sustainability of the system, not only of the health system, but of the entire Italian system, lies in placing the well-being of our citizens to the core of our considerations. It is the well-being of our citizens that has to be sustainable and equally distributed. If this is brought back to the core of our considerations, well, then many of the problems we have dealt with over the last few months can be faced and coped with, and we can provide a widespread quality-based level to our citizens. If we look at past weaknesses, I would like to add additional data. Child diabetes in our country, just to give you an example, is reaching levels which will not enable our country to face treatment for children in 4 years. So in 4 years' time, we won't be able to pay for the treatment of children affected by diabetes. So the problem here lies certainly in the money, in the financial resources which are missing. But the issue is not only an issue of treatment, which is definitely of great importance. It has to be dealt with properly. I completely agree with what was said before. But I think that treatment can be provided when you are no longer in a state of health. So probably the focus should be brought back to health and health prevention. Or being overweight or smoking were mentioned as risk factors before. These are major risk factors for any type of disease. So this means that we need to change our lifestyle. And this also means that we need to act on raising the awareness of our citizens on how important it is to adopt a healthy lifestyle, because this can help us preserve our health, which is not only our own health, but the health of our entire community and country. So we should all embrace a holistic approach in this respect. The network concept was mentioned. We're dealing with a complex situation. So when you're dealing with a complex situation, either you plan in this way, adopting these planning criteria, or you enter a given system and then you are no longer able of managing it from the inside. Complexity requires a network-based approach. That is why the consultation group of our Prime Minister in past months, and even before the health emergency, had started some reflections on a number of issues. For example, the redesign of territorial services addressed to individuals. The individual as the beneficiary of these services is very important. Of course, individuals are have important health problems, but actually human beings, individuals are also to be taken care of in terms of a psychological approach, in terms of health relations. I mean, all aspects of living have to be taken into account here. And the health aspect here will represent the most important one, but probably not the prevailing one. This is how the Benessere Italia consultation group to the Prime Minister works. It is made up of all the representatives and consultants of the ministers. So you may have a health problem, you may have a mobility problem, or a problem related to local territorial actions. I mean, these are all issues which are then intertwined. If you live in an environmentally more sustainable environment, means having a better health, and everybody has to be dealt with and approached with a systemic approach. So from the point of view of the government, this means that all ministries have to communicate in this direction, and the health of the person has to be brought back to the core of our work. But this does not mean that the burden should be given to just one ministry. It should be rather given to all ministries, because all ministries have the responsibility of favoring the well-being of citizens. And we have two objectives in mind. So first of all, we need to have a well-being that has to be equally distributed in line with what Mr. Anelli said before, and it has to be sustainable in all different nuances of sustainability. So the real revolution is this: as a country, we should once again have people at the core of our decisions. So people living in an environment that has to be preserved by everybody. If we take care of our own environment, that means that we take care of us all. And we have to make sure that these decisions then provide for a quality of life that is for everybody, not only of those who live this area, but also for future-born, so sustainability in a broader sense. So from a certain point of view, I think that all the recommendations, all the suggestions that have been put forward are certainly welcome. They are very much in line with the considerations that we within Benessere Salute Consultation Group were doing. So the concept of well-being does not mean that that our task is to kind of lace between all the ministries, but we have to establish relations also with the players who are active on the territory, like the ones represented here in this roundtable, as well as other players who are equally important, because they can equally contribute to the improvement of the quality of life of our citizens. Thank you, Professor Maggino. Thanks for your conclusions. We're perfectly in time with our schedule. I would like to close this talk by addressing all those who are following us with a recommendation which lies in the very title of our session. We need to get back to one's treatment, to one's cure. So, as you said, actually, the entire health system is ready to take care of you. So now it's up to you. It depends on your freedom to, trust the system and get back to your treatment, because we have seen that the impact of not treating yourself is more problematic looking at the future. So thank you very much for participating, and thanks to all the friends who have spoken during this session: Mr. Anelli, Mr. Corsaro, Professor Maggino, and Mr. Mantovani. So dear friends, thank you very much, and I wish you an interesting meeting. Thank you very much.